I don't know what they do for me.
Hi, everyone. We will get started in just a moment. Thanks for your patience. Everyone is on mute, so just to let you know, you're entering on mute.
Hi, this is Neel. Hello?
We just All right, we'll put it on mute again. And
Hi, everyone. Everyone should have been entered.
Right.
We're about to get started. If we can hear you, then you are in the webinar. Yes.
Can you hear
So
us?
please do mute yourselves.
I'm here, Marissa. It's Jamie.
Okay. We're going to go ahead and get started. So everyone should be able to see our screen. Sorry if we had a few technical difficulties, but we're gonna move it right along. So welcome everyone. We're really excited to have you joining us today to hear more about our online training module series, the life course perspective, and implementing early and critical period interventions to improve outcomes across the lifespan. We're excited to have some of our partners joining us today and sharing insights on their school readiness coaching program that's implemented in a pediatric clinic. Before we dive in, we want to share that this talk will be recorded and available online following the webinar. We will have a question and answer section at the end. If you would like to write a question in the chat box, please feel free to do so, and we will ask it at the end of the presentation. Please note all participants will be muted throughout the webinar. Please make sure you are on mute. Want to take a second and acknowledge that this project is supported by the Health Resource and Service Administration and the Maternal and Child Health Bureau. Just a little background on who you'll be hearing from today before we get started. My name is Marissa McCool, and I'm the Assistant Director of UC Berkeley's Center of Excellence in Maternal, Child, and Adolescent Health, which is housed at the School of Public Health. I've been leading the development and evaluation of the Maternal, Child, and Adolescent Health Life Course Perspective, Practice, and Leadership Training Module series that will be discussed today. Neel Patel is a general pediatrician and serves as the County Commissioner for First 5 San Mateo, which advocates and funds locally approved programs to improve children's health, school readiness, and family functioning. Jaime Peterson is a general pediatrician and assistant professor of pediatrics and public health at Oregon Health and Science University. She is a former middle school teacher with experience and expertise in early childhood education, school readiness, and school health systems. This is just a brief overview of what we'll be presenting today. First, we'll dive a little bit into what is the online training module series this webinar is based out of. Just a brief introduction to life course perspective and focus on early and critical periods. And then I'll be transitioning over to Neel and Jaime to talk about their example from the field. And as I said before, we'll have time for questions and answers at the end. So first, we want to provide a brief background about the Maternal, Child, and Adolescent Health Life Course Perspective, Practice, and Leadership online training module series, which throughout this presentation I'll refer to simply as the online training series. Here at the School of Public Health at UC Berkeley, we host one of 14 centers of excellence in maternal and child health, education, science, and practice across the United States. These centers are supported by the Health Resource and Services Administration's Maternal and Child Health Bureau, which I'll refer to as MCHB. MCHB's priorities and goals for the broader network of Center of Excellence are to prepare public health and healthcare professionals to be leaders in the field of MCH with culturally competent, multidisciplinary, community-oriented, ethical, and cost-effective vision of maternal, child, and adolescent health. To work closely with Title V and other MCH programs at the state, local, and national and global levels to eliminate health disparities and barriers to health, and build strong partnerships with other MCH training programs and centers of excellence, Title V stakeholders, and MCH communities to advance and share knowledge and skills, strengthen professional networks, and provide technical assistance in continuing education. UC Berkeley Center of Excellence implements a wide array of activities and programs to help support MCHB's priorities and goals. Some examples of these include, but are not limited to, our Masters of Public Health program in Maternal, Child, and Adolescent Health with an emphasis on leadership development. This includes both a traditional 2-year program and an accelerated 1-year program for individuals who already hold an advanced degree, such as a doctorate degree, or are current medical students. We also offer a concurrent degree with an MPH and a Master's of Social Work. We also host a postdoctoral fellowship program in MCAH epidemiology. We host a biannual research symposium conducted with University of California, San Francisco's Leadership Education in Adolescent and Young Adult Health Program, commonly known as the LEA grant. We provide technical assistance to local health departments and various community-based organizations, and we disseminate cutting-edge research to a broad network of partners, students, and alumni. As one of the activities of our center to support the continuing educational needs of the larger MCAH workforce, we developed this online training module series. The online training series is designed to provide an understanding of the life course perspective, its practical applications, and related leadership opportunities. The training module series is self-directed, online, and open source, which allows participants to learn at their own speed and convenience, completely free of charge. While the training is designed with clinical professionals and public health practitioners in mind, it is available to all learners, including students and professionals in other fields. The training series includes 5 modules, which are the overview of the life course perspective, health equity and social determinants of health, early programming and cumulative exposures to risk and protective factors across the lifespan, place matters, the impacts of physical, social, and economic environments on MCAH outcomes, and moving towards health equity, integrating a life course perspective in MCAH practice. Each of these models are centered on an interview with a subject matter expert in their respective fields, including Dr. Michael Liu, Dr. Paula Braveman, Ms. Kiko Mallon, Dr. Anthony Eiton, and Dr. Vijaya Hogan. Each module also has 2 key concepts that we highlight further through recommended reading, case studies of organizations implementing these concepts in practice, and additional supplemental resources. These key concepts include history of the life course, introduction to life course perspective, health equity, social determinants of health, impact of risk and protective factors across the lifespan, programming early and critical periods in the life course, place matters, the role of racism in shaping neighborhood conditions, leadership in MCAH, and collective impact. Now I want to take a few minutes just to give you an idea of what the training series looks like and how to navigate it. For some of you who have been engaged in the training, this may be familiar. What is showing here is the front welcome page. At the top, you'll see a navigation bar to click between different modules. On the welcome page, if you were to scroll down, you would see comprehensive background information on the course itself, its development, and its partnerships. Now, if you were to click at the navigation bar to one of the modules, this is what it would look like. For example, here we've clicked on Introduction module. It will direct you to the module page. What we're showing here at the top of the page is where we have provided learning objectives for that module to give you a better idea of what is included. If you were to scroll down on that same page, you would see the video interview with the key expert. This video, of course, can be viewed by the participant alone, but it can also be used in other settings, such as in an employee training, in a classroom, in a community meeting, etc. You'll notice at the top there are more navigation tabs. This is to navigate within the module itself, which I will show what all those sections are in one moment. Then below you'll see we have pulled out one key leadership theme discussed in the video interview. Now, each interview has a large variety of leadership themes addressed, but we wanted to pull out one that was instrumental in the discussion for participants to reflect on. So here we have navigated to the inner module navigation page, one of the first of the 2 key concepts. What you see is a list of recommended readings. These readings were selected carefully to provide participants a deeper understanding of the key concept. Again, all the readings are open access, meaning anyone can access them for free. Then you'll see the practice section where we have 1 to 2 case studies of organizations in practice. Here's what a case study looks like. They are 1-page briefs outlining the work of the organization and how it relates to the life course. These briefs are downloadable and can be used for your work. They can also be used in other settings such as employee trainings or classrooms. Here we have navigated to the second of the 2 key concepts in the module. In this key concept, we offer some supplemental resources. In the supplemental resource section, we provide a variety of additional resources that may include journal readings, online resources, other brief training videos, reports, implementation guides, and so on. And lastly in the module, we offer a reflection section. It's designed to have participants reflect on what they have learned in the series, and a copy of the responses will be sent to their email address. Lastly, we wanted to show you what we are calling the resource bank. Again, you will navigate here using the top navigation bar for between modules. Here you'll find the list of all of the resources for the whole training series, including a copy of the PowerPoint slides, readings, case studies, and supplemental materials. So if you're interested in just directing to this space and pulling all of the resources, you are welcome to do so. Now we're going to transition into providing an overview of both the life course perspective, but also early and critical period interventions, which is the foundation to the work we'll be presenting with our partners today. I'm going to show you a brief video that provides both an overall summary of the training module series itself, but also some foundational aspects we'll dive into today.
It's just a way of looking at life, not as disconnected stages, but as an integrated continuum.
There's a lot of strength to thinking about the life course perspective as a powerful way to do things differently. You know, the life course perspective is transformative.
We gotta start taking care of women and families, not only during pregnancy, but before pregnancy, between pregnancies, and across their entire life course.
When people talk about the social determinants of health, they're almost always referring to the influences, the social influences on health apart from medical care. We do know that there's a correlation between stress and poor outcomes. You know, stress in the body, how we respond to it, this whole concept of toxic stress, inflammation that results from it can precipitate something like preterm birth.
The conditions that we've created for people to live in, particularly for young children, have profound impacts on their entire life course.
Health equity means that everyone has a fair and just opportunity to be as healthy as possible. Coming together to think about how we could transform neighborhood conditions in order to have an impact on maternal and child health.
So our focus really ought to be on preventing or reducing the demand on the healthcare system by investing in policies that actually produce more opportunity for people, which will allow them to essentially be healthier. You've got to create social, political, and economic power and a critical mass of people living in these places so that they can actually hold systems accountable for equitable outcome.
You need community involved, so the people who are affected by the challenges that you're trying to address need to be a part of that table.
We need to infiltrate every decision-making body where key decisions are being made that really impact on the health of our nation's women, children, and families.
Create the type of leadership that we really need for this type of cross-sector work. We really need to create more leaderful organizations and more leaderful people.
Hopefully that gave you an overview of both what you would gain from participating in the online training, but also some of the information we're going to build on today. So just quickly, we want to take a few minutes to talk more about the life course perspective is and the concept of early and critical periods. We recognize that some of you are very familiar with this work and experts in your own right on these topics. We also recognize that some of you may be new to this work and are still learning about the life course perspective in general. This introduction will be rather brief and provide an overview of some of the foundational concepts in this work. However, we invite you to explore the online training module series as it provides more in-depth and detailed information on these concepts. The life course perspective is a conceptual framework for understanding health trajectories of populations over time. The life course perspective sets forth that broad social, economic, environmental factors do not only shape health and contribute to health outcomes, but are also underlying causes of inequities in a wide range of maternal and child health outcomes. The life course framework helps explain health and disease patterns, particularly health disparities across populations and over time. Instead of focusing on differences in health patterns of one health outcome at a time, life course points to external factors as underlying causes of persistent inequalities in health for a wide range of health outcomes across population groups. The life course perspective is population focused rather than focused on one individual and is rooted in social determinants and health equity. The social determinants of health are conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. The social determinants of health are most are mostly responsible for health inequities, the unfair and avoidable differences in health status within and between countries. Health disparities are health differences that adversely affect socially disadvantaged groups. Health disparities are systemic, plausibly avoidable health differences, for example, according to race, ethnicity, religion, income, so on and so forth. Health disparities do not refer generically to all health differences, or even to all health differences warranting focused attention. Rather, they are specific subset of health differences of particular relevance to social justice, because they may arise from intentional or unintentional discrimination or marginalization. In addition, they are likely to reinforce social disadvantage and vulnerability. So then what is health equity? Dr. Paula Braveman and her colleagues at the Robert Wood Johnson Foundation define health equity as everyone having a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and a lack of access to good jobs with fair pay, quality education and housing, safe environments, and health care. Now, risk factors are conditions or variables associated with a lower likelihood of positive outcomes and a higher likelihood of negative outcomes. Positive factors have the reverse effect. They can enhance the likelihood of positive outcomes and lessen the likelihood of negative consequences from exposure to risks. Some examples of risk factors may include exposure to poor air quality, barriers to accessing healthy food, exposure to violence, while some examples of protective factors may include father involvement in a child's life, opportunity to have quality education, and access to safe and reliable transportation. These, of course, are just a few examples. However, there are many. So how is the life course perspective, including concepts of social determinants of health and health equity, related to risk and protective factors? Risk and protective factors are often conditions or variables that are social determinants of health, whereby working to increase protective factors and decrease risk factors among individuals and communities may greatly improve their life trajectories and the health outcomes we see in populations, and ultimately reduce health disparities. One way of focusing the prevention of health outcomes over the life course through the reduction of risk factors and/or increasing protective factors is by implementing interventions at early and critical periods across the life course. By reducing risk factors which make individuals more vulnerable to disease and other health conditions, while increasing protective factors which mitigate risk and enhance resilience that support optimal health, during early and critical periods, we may be able to greatly improve the health trajectory of not just individuals, but families, communities, and generations. Some examples of early and critical periods include during pregnancy, early childhood, and adolescence. These are sensitive periods of early growth and development, where the development of the brain and the body are highly receptive to a wide range of environmental exposures, that is, risk or protective factors. If interventions are able to improve social conditions such as environment, economics, access to resources, and so on and so forth at these critical and early periods, then individuals, families, and communities may be able to establish lifelong positive outcomes in emotional health, physical health, reduction in stress response, improved immune system response, and positive health-related behaviors such as consuming nutritious food. So through this two-part webinar series, we'll be sharing an example of implementing an intervention at an early and critical period, one focused on early childhood and one focused on adolescence. Today, we're thrilled to have Dr. Patel and Dr. Peterson here to talk about their intervention focused on early childhood. The case study of their intervention, which I'm showing here on the screen, is a part of our Module 2 in the online series, but today they're going to dive a little bit deeper than what this one-page brief is able to describe for their intervention. So I will be passing it over to Neel. And let's see.
Marissa?
Yes.
I believe we'll be starting with Jaime.
Oh, okay. Jaime, can you hear us?
Hello?
Yes, you're on.
Thank you, Marissa. Dr. Patel and I are very excited to share our experience with this very unique clinic-based school readiness coaching program that really grew over time to support parents in the first 5 years of a child's life, which, as Marissa pointed out, are incredibly critical for brain development. For those of you on the webinar, when we talk about school readiness, it's generally defined as a child's development in 5 different domains: physical development, social and emotional development, approaches to learning, language development, and cognitive development. School readiness is a critical period of development because children who start kindergarten ready to learn are more likely to succeed academically in the future. However, we know that low-income and minority children often enter kindergarten less ready than their more affluent peers. Factors that contribute to this include living in poverty, learning English as a second language, low maternal education, and limited access to books in the home. This essentially creates a school readiness gap. And in the United States, we unfortunately lack a comprehensive early childhood education system to help parents prepare for school. Fortunately, with the passage of the Affordable Care Act, almost all children do have access to a medical home with a trusted pediatric provider. At our former clinic, the Fair Oaks Health Center, a county clinic in Redwood City that serves many low-income minority children, many children rely on either Medicaid or the Children's Health Insurance Program. In 2017, it was a medical home to over 3,000 children who were largely Latino and Spanish speaking. In 2017, the preferred language was Spanish, with 77% of patients requiring a bilingual provider or trained medical interpreter. At this point, I'm going to have Dr. Patel talk about how the clinic was able to leverage this important relationship with children and their families to try and address the school readiness gap early.
Thank you, Jaime. I'm not able to advance to the next slide. There we go. I'm trying to. Jaime, maybe you can just forward it. I think I got it. Okay, great. Thank you, Jaime. I will now take you through a brief history of the school readiness appointment model. It has certainly been a labor of love. The school readiness appointment model at Fair Oaks Health Center was developed over a long period of time with the support of many community partners. I will briefly walk you through the history to highlight how strategic, non-traditional partnerships led to the development, funding, and evaluation of the intervention. It began in 2006 after the American Academy of Pediatrics released a statement to support healthcare professionals in developing a pattern and practice for addressing developmental concerns in children from birth through 3 years of age through the use of validated developmental screens. This led to the implementation of standard developmental screenings with the PEDS and MCAH screens at the Fair Oaks Clinic. The screenings, once initiated and incorporated in the well child visit, led to an increased number of children identified as at risk for autism and developmental delays without a clear or timely plan for assessment. We first partnered with AmeriCorps to assist with secondary ASQs and provide some basic connection to resources. For autism and more high-risk patients, we founded partnerships with First 5 and Stanford to help secure a developmental pediatrician on site, embedded in the local clinic, becoming a host site for the training program with developmental pediatrics at our local academic institution. Over time, developmental screening rates and assessments improved. However, we then began to notice that children with mild speech delay were returning for ADHD assessments because they were struggling in school. We began to expand developmental screening to include a parent and child school readiness screening to help support parents earlier or just before entry in the elementary school setting. Then in 2012, Jaime joined Fair Oaks as a pediatric resident and led a needs assessment and program evaluation. Over several years, key partners such as the School of Medicine, First 5, and the larger San Mateo Medical Center were engaged deeper to eventually help support a full-time community health worker. Next, I'll be going to the next slide. Great. Now a little bit more about funding, which can always be a little tricky. Funding definitely went from nothing to something with ups and downs in between. What you see here is the same timeline described in the last slide, but includes some key stakeholders who were recruited to help with the funding. Generally and definitely initially, there was no direct funding. Much of the service was leveraged or done through partnerships. To develop and incorporate the developmental screening program, there was some ability to implement developmental screening through existing clinic funds, but none to do the heavy lifting, education, or coordination. For this, we partnered with First Five for training and Stanford. Then we volunteered to become a placement for an AmeriCorps volunteer, taking advantage of our location in an underserved community. The partnership then progressed with Stanford, where we offered ourselves as a community site for training of fellows. Then we tried to encourage clinic funds indirectly, or we tried to engage clinic funds indirectly by offering areas of development and expertise for the RNs in our clinic. And thankfully, one RN volunteered to specialize in development and perform school readiness screens. This was actually a key development in terms of success and an important step to incorporate the work into the daily clinic. It still, however, was not much. Then First Five recognized an opportunity for care coordination and offered to place a care coordinator part-time in the clinic. We also leveraged the School of Medicine and residency program to send enthusiastic students and residents. With Dr. Peterson's arrival, she took it all to a new level and added the important evaluation piece which was missing entirely. Local foundations, including the local hospital foundation, were engaged to provide some funding and donations, such as puzzles and parent packets for school readiness visits. This was administered through clinic administration and the earliest example of blending funding into the clinic budget. Then over recent years, funding by First Five for care coordination and screening was weaned, and the clinic was asked to contribute more. Also, existing resources were repurposed to provide more support for a full-time community health worker in the clinic to do school readiness appointments. It was a long road, and seeds planted early did reap rewards later. I would say we never found a pot of gold, but we did lots of creative and continuous collaboration to slowly build up our program. Next slide. So I'm going to ask for the full slide to be shown. So this is a slide, I'd like to bring it back to our actual school readiness appointment. This was a novel idea, as much of the literature and experience was more with development and autism. In our case, pediatric providers could refer children 3 to 5 years of age for a 1-hour school readiness intervention with a bilingual community health worker. The referral typically was based off of surveillance or concern on a developmental screen and usually was done for children who were about to enter preschool or kindergarten. During the 1-hour visit, the child receives a school readiness assessment with a validated school readiness screening tool, in our case the BRACEN, and also sometimes the ASQ-SE. And the results are shared with the parent and used to drive a 45-minute intervention with the parents, with 3 components. One was modeling. For example, how to talk about colors when getting dressed in the morning. Next was resource facilitation, with distribution of resources such as library cards and preschool enrollment forms. And third were educational tools, for use at home such as books and puzzles, and sometimes educational toys. Next, I'll turn it over to Jaime, who evaluated this work to demonstrate its meaning and value, something that we intuitively knew, but Jaime took what was intuition to actual data-driven evidence.
Thank you, Neel. To evaluate the impact of the school readiness intervention, we designed an intervention cohort study, and we did this at the peak of funding in June of 2016, when the most children were receiving the intervention. Thanks to the collaborative efforts of First Five and San Mateo Medical Center, the intervention was much more widely available from June of 2016 through February of 2017. During that time, 74 3 to 5-year-old children received the intervention out of 76 that were referred. That means we had a no-show rate of 2, which is exceptional for our population. We then selected 75 children who were also 3 to 5 years of age to be the control cohort. That's shown here in the purple. These children did not receive the intervention, but had a regular well-child check and were matched by age and gender to be as closely matched to our intervention cohort. Then 6 to 9 months later, we conducted semi-structured phone interviews with the parents to determine their behaviors and barriers that were related to school readiness. The study was approved and overseen by the institutional review boards at both San Mateo Medical Center and Stanford University. I'm going to show you some of our major results. In our analysis, we found then that when looking at the frequency of different school readiness behaviors, both the intervention and the control groups were doing many positive early school readiness behaviors. You can see here along the x-axis the 13 different behaviors we measured, from telling a story all the way to helping their child do a puzzle in the last week. On the y-axis, you can see the percent of parents that reported each behavior in the last week. Overall, you can see that while parents in both groups are doing some positive behaviors like teaching colors and counting, the intervention group has a higher frequency of almost all behaviors. They're shown in turquoise while the control is shown in purple. The behaviors that reach statistical significance are shown in this yellow box. Telling a story, visiting a library, and teaching letters were statistically associated with having received the intervention. The next slide will show the adjusted multivariate regression models for parent behaviors and barriers. This model is adjusted for birth order, preschool experience, maternal employment, language, and maternal education. You can see in these adjusted models, the intervention parents were 14 times more likely to tell a story, 3.7 times more likely to visit the library, and 3.6 times more likely to teach letters with their children in the last week. You can see here, this is the green line. This represents the null of 1. Many of the behaviors were more likely to occur in the intervention group, but the confidence intervals crossed the null. These 3 were statistically significant. The next slide, you will see that when adjusting for birth order, preschool experience, and maternal employment, parents in the intervention group were less likely to report school readiness knowledge and having to care for other children as barriers to school readiness. Again, you can see general trends that all of the barriers were lower for those who were in the intervention, but only 2 had confidence intervals that did not cross 1. We then conducted iterative theme analysis of the intervention parent interviews to better understand the actual parent experience with the school readiness coach and intervention. In these analyses, we found 3 major domains emerged from our conversations with parents. The first was around the school readiness appointment itself. The second was around community school readiness resources that existed. And the last was about parent school readiness knowledge in general. Starting on the left, within each domain, there are several sub-themes. On the left, under the school readiness appointment, you can see that the major themes that emerged were that parents had an increased awareness of what their child needs to know for school, a better understanding of their child's strengths and weaknesses based on the Bracken assessment, and they increased their actual behaviors, as we saw in the quantitative analyses. In domain 2, we found that parents enjoyed the visit and recommended it for other families in the community, and they also were connected to new resources such as the preschool, library, or things like gymnastics. In the last domain, parent school readiness knowledge, we found that parents continued to have varying understanding of school readiness. They rely on their siblings of their other children, the siblings of their children, and teachers' feedback to gauge their child's school readiness. And overall, they reported that they felt uncertain in their abilities to help their child, but have a high trust in both teachers and their pediatricians. I will share 3 parent quotes to help characterize the parent voice for several of these themes. This quote reflects the theme that parents really valued the one-to-one nature of the appointment, and they appreciated the recommendations offered by the health worker. One parent stated, "Well, I would like for there to be more people like the health worker who help me to give advice to mothers about how to help prepare their children, because that's useful, because a lot of mothers we don't know. It might help to have more people to teach us how to prepare our children." The second theme I'd like to show represents the theme that parents change their behaviors after the intervention. The first parent states, "Before the meeting, I had no idea what he did or did not know and what we could be doing to help him prepare for school. After, I knew how I can help him practice these things like colors and counting at home, and that I need to help him with his reading." The second parent stated, "The appointment was very useful. It pointed out the things that my daughter needed to work on. She gave me a list and she gave me helpful advice. She gave me a few activities for my daughter. I used these tips and my daughter's doing great in preschool, so I'm really proud of her." This last quote reflects the theme that despite the 1-hour intervention and routine well child care, parents continue to have a varied understanding of what it means to be ready for kindergarten. Parents define being ready as self-help skills, which are important, like potty training, or as language skills, like the need to speak English. Parents often stated 1 or 2 domains of school readiness rather than all 5 domains. This suggests there is a need to support parents through the early years before and beyond the timing of this actual intervention. In conclusion, with this particular study, which is both a quantitative and qualitative analysis of the intervention, we found that a brief school readiness intervention that was directly embedded into the clinical home was well received by low-income Latino parents, and importantly, it increased early literacy behaviors such as telling stories, reduced key barriers, and was able to connect families to existing resources in the community. This coaching program is an example of how the child health system can be a partner with the early childhood sector to support the unique needs of their clinic population. Latino children are a vulnerable group growing in numbers, and we have the opportunity to impact early learning behaviors known to be associated with school readiness in the future life course. Next steps for this program include extension of the coaching model into other clinical settings, further research, linked to school data to determine if these findings persist and truly improve school readiness rates for low-income children. 3, advocacy for policy that creates enhanced payment structures between health centers, community organizations such as First 5, and schools that could foster innovative collaboration, as it did in this program, to improve the local school readiness of our children. And finally, we hope to see the health system strive for evidence-based enhancements to the standards of well child care to incorporate things such as school readiness prescriptions or school readiness coaching with attendant pay. We would argue that school preparation and parental support early in a child's life is the right care at the right time in a trusted setting. We will now switch gears shortly, and Dr. Patel will walk through practical tips for implementing a similar model with your own community before answering participant questions.
Great, so this slide is dedicated to some global learnings over the years. We realize that it starts with paying attention to your environment and being on the lookout for what is needed. Make sure your new idea is in alignment with your daily work and that it somehow enhances it. Consult with local and internal experts. Identify and work with key stakeholders who are enthusiastic and have the means to help. Work with specific individuals who are passionate for the same thing. And in terms of stakeholders, be flexible to let partners go and acquire new ones as they may change over the years. Start small, blend funds, piece it together. Blend in local everyday funding slowly and align your new work closely with the daily work so that it piggybacks without too many people noticing. Leverage symbiotic relationships for physical and human resources. And keep going. Realize that it takes years. And most importantly, don't forget to evaluate and celebrate small and large successes, which is so important to keep the work going long term. Next, I'll turn it over to Marissa to wrap up our presentation.
Thank you both. We are going to pause for some question and answers. If you have questions or comments, please put them in the chat box. The chat box can be found if you move your mouse. On the bottom, the black bar should appear, and there's a little bubble that says chat. We know that was a lot of information in a short amount of time, and both Neel and Jaime would be happy to answer any questions you may have about their intervention, their successes, challenges, anything like that. So I'll give a few moments if anyone would like to ask any questions. So we do have a question. Did the cohort group have any developmental delay concerns?
Thank you, that's a great question. We found that those who were referred for the intervention were referred for 3 different reasons when we went back to the referrals. One was just a general school readiness appointment because they thought they were between the age of 3, 4, and 5. The second were those with maybe concerns for mild delays, maybe shy, timid, but nothing that had screened positive on screens. And then the last were parents who just felt like they wanted more support in general about community resources or how to help their kid after getting their Reach Out and Read book. We excluded any children who had a diagnosis of delay from our final analyses. So if we went back and looked and they actually did have speech delay or development delay or a seizure disorder or had been premature, we ended up excluding them from the analyses that you saw.
Thanks, Jamie. So the next question and statement says, lots of coaching programs show benefits to repeated intervention. Have you tried any follow-up coaching, or are you hoping to try follow-up coaching?
Yes, I think we don't show this because we don't have a large sample, but several of the kids who were either delayed or very delayed on the assessment ended up coming back in a couple of months to be reassessed. And many of them actually showed improvements. They went from, quote, delayed on the school readiness assessment, it's not a developmental assessment, to either delayed or average. It's something I think is important, and we've been having a lot of conversations of, is it too late to be doing this at age 3, and should we be doing this first round, at 18 months to 2, and then doing a follow-up somewhere before school starts at 3 or 4?
Thanks, Jamie. The next question is someone asking for an example from Neel about how you align the intervention with what was already going on, so the changes maybe weren't as noticed as much.
Yeah, so one of I think my favorite examples is of the nursing. We happen to have, sort of a call to see how we could elevate the scope of the practicing nurses and MAs. And so we looked to it didn't have to be necessarily out of nursing, but we just basically looked within our existing job descriptions to see where small or minor tasks could be added, and sort of worked with the different, whether it was the front desk or nursing, to see where was it that we could add specific things that would support this program. And we sort of had a big win with the nurse that we actually found, who was actually interested in diving deeper in this area. But that would be an example of really looking to, we had to be very careful about making sure that we didn't add sort of new things or having people not work outside of their job description. And so we went back to the job descriptions and said, this is something that we can add. That would be an example.
Thanks, Neel. The next question is kind of related to, Jamie, what you were saying before, but someone's wondering, did you see a different effect or an increased effect the younger the child was on these results?
That's a great question. And I don't think we've actually stratified it by age because it makes our sample smaller. We did notice that it was more sensitive to children who were firstborn in the family and were primarily Spanish speaking. So we've been asked in terms of scalability, if it's not possible to offer this to all children in a clinic, who would you prioritize? And so for our own clinic, I think it would be to say the firstborn child in a family that is mostly Spanish speaking would be where I would prioritize funds.
Thanks. And we got a question about, did you all get any kindergarten report cards to confirm your results, given that the data you had was from the parents and their perception, which, has some potential different biases?
That's a great question. And we're hoping actually all of those kids who were 3, 4, and 5 in 2016 have now entered kindergarten. And many of you know that through the Big Lift, they've been taking the Brigance in most of the school districts. And so we're hoping to have their school readiness scores in the next couple of weeks to match them. And we would hope we're going to look for a difference in their actual performance on that assessment between the intervention and the cohort. So stay tuned.
Thanks. Any other questions or comments from the participants for Jamie or Neel? Those were all really great questions. And as I said before, their intervention and their evaluation is really rich and deep. So we definitely couldn't cover it all in just a short amount of time. But we're happy to field any other specific questions about their experience or questions you may have about implementing a similar approach in your setting or organization or community or other space. And Neel and Jamie, while we wait to see if there's any other questions, do you have any other comments? We do have a question about, someone indicated, impressed by the creative way that you integrated the services. Is Kaiser doing this?
So I'll take the Kaiser. So I'm not intimately familiar with Kaiser's process. I know that Kaiser does do A lot of their sort of homegrown or sort of in-house development of it. In terms of school readiness, I'm not, I myself, Jaime, I'll defer to you, but I'm not aware that they actually specifically call it out as school readiness.
Hmm.
I'm not aware either, but if anyone has experience with it as a patient and you think they do something similar, it would be great for us to learn about.
Thanks. Is there any plan to share your approach with other health facilities, or have you already done some of that?
It's a great question. I'll go first, Neel. We shared the findings with First Five at one of their meetings last fall, and there is an effort right now underway at Ravenswood Health Center in East Palo Alto. They're trying to implement a host of things related to school readiness, and one of them is the coaching model. And so we gave them our structure and resources. And then I am actually now up in Oregon and having conversations here with our local clinics and the health share, which oversees the Medicaid plan for children, to see if there's a space for us to do it here. So we would love to see it grow.
And I would say there is still, a lot of work that we are doing currently through First Five in the area, still a developmental screening. So we recognize that there's that is sort of an older approach that is more mature, and we are definitely working on developmental screening, and the school readiness, dovetails to that. I will say at the one thing that we're looking at that's very interesting is really thinking deeper about what the 30-month visit looks like. Classically, in many systems, there isn't necessarily a 30-month physical. There's a 2-year physical and then a 3-year physical. And as we define the model of what a 30-month visit looks like, the developmental screening, and we're, as we look at it, we're seeing that the developmental screen kind of would benefit from a school readiness type screen as well. And really, how can you accomplish that is a different story. And we have some things that we are looking at which are quite innovative, like the SWIC as the developmental screen. I'll kind of stop there. It's a big topic.
Thank you. Yeah, we have one more question. Someone shared that they already have Reach Out and Read and periodic ASQ screening. Did this exist in your program before the intervention?
Neel, do you want to? They have Reach Out and Read in place at this clinic, and it had been before the intervention had been developed over time. And then in terms of ASQs, as Neel pointed out in 2006, they weren't routinely doing developmental screening. And so with that call, the PEDS and the MCAT is actually the first pass for screening, correct, Neel? And then follow-up ASQs as needed.
Yeah, and I know at some clinics the ASQ is sometimes the primary pass, and both have been validated. The ASQ was sometimes often a secondary screen at Fair Oaks. And then in terms of the Reach Out and Read, I do think that the Reach Out and Read was an already established and also, I guess, more mature and older program. And I do really believe that a lot of the work for Reach Out and Read was very much sort of foundational for the developmental screening to take off. Because when we started developmental screening, thankfully, because we had Reach Out and Read, there was already an intervention in place. But before, we never did it in the context of developmental screening. We just gave a book because we intuitively knew it, and Reach Out and Read was already in place. So that Reach Out and Read existed prior to it, and I believe still does. And thankfully, that was in there so that we could say that we were doing something with the developmental screening once it got started back in the early 2000s.
Thanks so much. We're going to close out the Q&A. Just a few brief announcements. We will work on sharing the slides in some format and contact information, as well as the recording, which we will be sending out to get captioned, so that may take a few days. I also want to take a moment and acknowledge both Neel and Jaime and First Five. Oh, that says Alameda. It should say San Mateo. San Mateo Medical Center, HRSA, MCHB, and all the collaborators on the online training project, which is far too many to list here. And I want to take a moment If any of you are interested in our next webinar, it's focused on another critical and early period, which is adolescent health. So that will be on May 28th from 12 to 1. Again, we thank you so much for spending your lunch hour with us, and sorry for any technical difficulties. We'll get all the related materials out to you all as soon as possible, and hope that you found it a useful portion of your time. And thank you so much. Have a great rest of your week.